So just handing over firstly to Chris Bishop, followed by David and then Debbie. So Chris.
Oh, thank you very much, Minister. Look, I thought we might start with the Crown Plaza, because that's obviously the area that a lot of people are interested in, and particularly when it comes to finding out exactly how we got into this situation. So my understanding is there are currently 6 members of the public who are of interest at the Crown Plaza in relation to the walkway, and 2 people are still unidentified. So what's being done to find the missing 2 people who could potentially still be going to, out to essential businesses, not knowing that they're of particular interest to this inquiry?
Yeah, look, I'll get Dr. Bloomfield to give you the latest on the case investigations around the Crown Plaza. A couple of points before I do that, though. At this point, we do know that there'll be a link in there somewhere. We don't know what the link is yet at this point, so we're running down every possible avenue. The Crown Plaza is currently empty, and some further work is being done to strengthen even further the public health measures around that. Some questions around things like alleyways and corridors and so on. I can confirm the Crown Plaza is the only one that has that nature of a challenge. The others don't. The other inner city facilities don't. So we've been having a good look at that. But I'll ask Dr. Bloomfield or Dr. McElnay to comment on the case investigation aspects.
Well, thanks, Minister, and kia ora koutou committee members. Yes, so there is a specific team at Auckland Regional Public Health working on the source investigation, and they are working with the police around the CCTV footage of those members of the public who could have been in the area when the person who we believe was the source of the outbreak was being transferred into the hotel. I think my understanding is that, yes, there are still 2 people from the 6 that haven't yet been identified. Someone volunteered overnight on Twitter that they may be one of those people, and we are following that up this morning, and Auckland Regional Public Health were getting in touch with that person first thing this morning. They have released the date and time to the public to ensure that anyone who was there is able to come forward. But at the moment, that's one aspect of the ongoing inquiry about how the virus may have got from the hotel out into the community.
Okay, just in relation to the Crown Plaza, when was the last infection control audit done at the Crown Plaza, and did it raise questions about the setup of the public areas around the Crown Plaza, particularly in light of Delta, which, as everyone knows, is so contagious?
So I could say the MIQ team will be with us tomorrow to get into that. The infection prevention and control audits are done very regularly of all of our MIQ facilities. That looks at everything from the physical layout of the facilities to what the staff are actually doing. And so, yes, there will have been a recent review of the Crown Plaza, and the MIQ team do that in conjunction with health. So I'm not sure whether health are in a position to provide a comment on that, but if not, we'll certainly be able to get into the detail of that tomorrow. But I'll invite the health team if they do want to.
Just quickly, and I don't have the date of the last IPC audit, but on the last round, this wasn't raised as an issue. And I've also just had updated information that those 2 people have now been identified and are being interviewed, the 2 that were previously unidentified.
Okay, that's good news. Can I ask around, we might want to get more into the Crown Plaza tomorrow when you've got the MIQ team with you, Minister, but can I turn then to contact tracing? And is it fair to say that the Dr. Aisha viral metrics, which have become known as the viral metrics, is it fair to say that those are no longer being used by the government to measure performance of contact tracing in light of the Delta variant?
They're still being used, and they're still a useful thing for us to benchmark against. But I think Dr. Viral herself would argue, and in fact has argued, that those metrics were designed for effectively a different virus, an earlier version of the COVID-19 virus that was not as quickly infectious as this one is. And so as a result, some of those metrics won't look as, will be much more difficult to meet. The targets in those metrics will be much more difficult to meet. So yes, we're still using them, we still report against them, but I think we have to have a realistic expectation that they were put in place when we were dealing with a virus that had a sort of an incubation and then subsequent infectious period of 3 or 4 days, and now that can be less than 24 hours. And so that does change the nature of the game.
I mean, why? I suppose the obvious question is why haven't you designed new metrics to measure the government or measure the contact tracing against? Delta's been around for a few months now, in fact, quite a while. The viral metrics were April 2020, so we're sort of 16 months on. So why has there not been a sort of updated performance measure so that we know what we're dealing with?
Our understanding of Delta, yes, Delta's been around a while, but our understanding of it grows by the day. And really, it would only be in the last sort of few weeks to a month that we've really sort of understood some of the challenges around the speed with which it transmits compared to earlier variants of the virus. And so, yes, we keep the whole system under review. It's not just the fact that we haven't released new metrics doesn't mean we haven't been considering very closely some of the things that might need to change and that are already changing as a result of Delta. So a lot of work has gone into considering how a response to an outbreak would be different in the Delta environment, which is what you're already seeing over the last week. We're moving much faster than we have before because a lot of planning's gone into preparing for that scenario. Things at the border are switching up. So we're doing more testing in MIQ more frequently and earlier in the piece. That was actually introduced in response to a previous variant of the virus that was at that point more infectious than earlier versions. And now we're dealing with something even more infectious again. So we're constantly looking at what more we need to do. Things change all of the time. I'd note that we've done dozens of reviews, including of what we measure, how we measure, and what's important. They've resulted in something like, and Cheryl Barnes will be able to tell us the exact number, something like 1,200 different recommendations. And the team, I use that as illustration to show that this is something that is being looked at all of the time. This is not a system that's standing still.
Okay, one further question in relation to contact tracing and surge capability. I'll refer you to the review of the Auckland February 2021 outbreak and our current response capability, which was undertaken by Professor Philip Hill and Dr. Debbie Ryan for the Continuous Improvement Group, particularly paragraph 5, which noted that the risk of a large outbreak in New Zealand is real, and basically it said backup surge capacity should continue to be substantial. And it said, we do not agree with the Ministry's assertion stated to us that it is not necessary to increase the standing or surge capacity in New Zealand, or the assertion that this is not possible because there is the lack of an available workforce. What that seems to be saying is that back in relation to the February outbreak, and now we're of course in August, the Ministry's view is that it wasn't necessary to increase the standing or surge capacity in New Zealand, or in fact that it wasn't even possible. Do you accept that? And if so, why? And if you don't accept that, why has the work not been done in the last few months to increase surge capacity so that we can contact trace as quickly as possible?
I'll get the health to comment on the reports of their comment, but before I do that, one of the things I would note about the current outbreak that we are dealing with now is we are dealing with many, many more contacts per case than we ever have before. And in fact, the system that Dr. Verrill put in place was designed on the basis of a handful of contacts per case. And actually, we're doing a lot. So we have thousands and thousands of contacts in the system now that are being managed very effectively by our contact tracing system, including a degree of triaging. So you're identifying the highest risks contacts to the lowest risk contacts. And that system's working very well. But the outbreak that we're dealing with at the moment, another complicating factor and one that I think no one who has done a lot of the modelling necessarily built this into their thinking. These cases are a younger demographic and much more active in large-scale events than in anything that we've seen previously. And as a result, again, that puts pressure on our contact tracing system. I would say that my observation from the information that we're getting is that our contact tracing system is rising to that challenge remarkably well. That's not to say it's not a system that's under pressure. It absolutely is under pressure. But in terms of those comments about health's position, I'll invite the Director General to comment on that.
Thank you, Minister. So what I would say as Chief Executive of the Ministry of Health is that's not a view that I did or do hold, that we didn't need to continue to build surge capacity, and indeed we have. So all of the public health units around the country who are currently involved and have been from the start in the contact tracing response to this outbreak have got surge capacity, and they have surged up with all that additional surge capacity.
Why?
One question, Chris, and then we do need to move on to
sure,
the next member.
Absolutely. But I just want to pick up on that. I mean, why is there therefore a report by the government's own expert advisors? These experts were commissioned by the government to provide advice, saying that the ministry's assertion, that the ministry asserted to them it was not necessary to increase the standing or surge capacity in New Zealand. Are you now saying, Dr. Bloomfield, that that's not the position of the ministry? And if so, why was that reflected in the report?
Well, I can't speak to why it was reflected as such in the report, but it's certainly never been my position nor of the senior leaders here in the ministry. And I dare say we have got significant surge capacity, and I think that's borne out in this outbreak. In the first week of the August outbreak last year, there were about 1,500 close contacts, and we now have over 15,000 close contacts in the system this outbreak. So that has been dealt with because we have built the surge capacity necessary.
Okay, thank you, Dr. Bloomfield. Across to David Seymour and then Debbie Narua-Packer.
Oh, well, thank you, Madam Chair. If I could just ask a very quick technical question to Dr. Bloomfield. Have you issued any Section 24 exemptions under the Public Health Order for alert level requirements? And how does one go about applying for one?
I'm sorry, I'd have to come back to you on that specific question. Is there something in particular you have in mind about a Section 74 exemption?
Section 24 of the Public Health Order, Alert Levels number 9. I just wonder how somebody goes about applying to one. Do they write to you, or how does that work?
Well, I'll come back to you on that. There are a number of exemption processes in training. You have to forgive me that I don't know which ones relate to which specific sections of the order or the Health Act, but we certainly have information.
Okay, well, look, if you could email me, I'd be very grateful. Thank you. Just to the Minister, I just wonder how many of the 15,741 current known contacts have returned a test, positive or negative?
I haven't got the exact numbers. Dr. McElnay or Dr. Bloomfield will have the most recent, but what I would point out is that people get tested on a cycle, and people aren't always tested immediately as soon as they're identified as a potential contact. In some cases, the team will wait a day or two because if they've only just been potentially a contact, they may not be tested straight away. They'll be entered into the system as a contact straight away, but they may not be tested straight away. So I'll see if the team have the most recent.
Well, just before you go any further, I mean, wouldn't you agree this is a pretty important number? Because at the end of the day, you need to test people, find they're negative, and basically re-release them before this thing is over. So surely, you talk every day about how many tests have been done, but not how many have returned, and not how many of them were actually people who'd been in locations of interest. I mean, I think this is a very important number. How many people who are contacts have actually returned a test result?
Well, test results, of course, are being processed all of the time, and the number is changing all of the time. I don't happen
What's
to have
the latest number you know?
Well, I've just referred you to the team who will have the latest number.
Okay.
Sure. Dr. McElnay can just speak to the latest report we have on that.
So the report that I'm referring to came in this morning, and these reports are constantly updated. We categorise contacts into 3 different categories. And that's a risk-based assessment. So I've got some figures for the different categories. The highest risk contacts are what we call close plus, and for those we have a result. 51% of those we have a result back, of which 11% were positive. For the close contacts, which is the largest number of contacts, that's the 14,967, we have 56% of results back on that group, and 0.2% so far are positive. And for the casual plus, which is a lower level of risk, we have 405, of which 58% we have a result back, and none of those have been positive.
So just so I understand, how many high risk did you say there were?
369.
Okay, so you've done half of those and about half of 14,000. So So you've done 140,000 tests, but about 7,000 of them were people who are a close or close plus contact.
We have results back for by 8,500 of those that are close plus and close.
Right. Okay. No, well, thank you for that. Can I just ask to Chris Hipkins? The Prime Minister was interviewed this morning. She was asked if she would be trying to negotiate more vaccine supply. She said, we don't need more vaccines. Do you agree with that, or will you be making any effort to pick up the phone to Pfizer, try and increase the pace of delivery, or will you talk to other vaccine providers? For example, 7 weeks ago, MedSafe approved the Janssen vaccine. The Prime Minister at the time said Cabinet would consider deploying it. Has Cabinet made that decision, and do we expect to see any other vaccine types deployed anytime soon?
A few things in that question. We're talking to Pfizer all of the time about not so much about whether we have enough vaccines, but the timing of the delivery of those vaccines. So we've got about 10.5 million doses of the Pfizer vaccine coming into the country this year. The question is the timing of when particular shipments get to New Zealand. So we know that from October onwards, we'll be getting a lot of vaccines between now and September, which is, the next sort of 5 to 6 weeks. We'd like to get more sooner, and so we're constantly talking to them about that. They've been good at so far at over-delivering, so delivering more than they had previously committed to. In terms of beyond this year, we know that if everyone who's currently eligible, if we get 100% uptake of everyone who's currently eligible, we won't use up all of the 10.5 million odd doses that we've got coming into the country. We will have some extras, and that potentially between 1.5 to 2 million of those. That gets us well set up in the event that we do decide to start doing booster shots, and we haven't made the decision on that yet. We're still following the international evidence on that, and MedSafe still have to go through a process on that. But we would be able to start those for the people who would fall due. Say it was an 8-month gap that was decided, we would be able to start them based on the supply that we know we will have this year. Then we would need more in next year, and we're talking to Pfizer about that. In terms of the Janssen vaccine, yes, it has been approved by MedSafe. Yes, I have met with myself with the Johnson & Johnson team who represent Janssen. They have indicated that a quarter-3 delivery is almost impossible for them. That a quarter-4 delivery may be possible, but would be challenging. They've yet to come back to us on that. So we're in talks about them. Obviously, there's a degree of commercial negotiation about that, given we have an agreement with them. And so, we are, at this point, we're not in a position to take delivery because they're not in a position to deliver any to us. But we are obviously talking to them about that.
So
Thanks, David. Just final question, David.
Oh, final question.
Yeah,
okay.
Just before we move on. Yep.
All right. Well, can I just ask, Minister, 3 weeks ago on this committee, I asked you what sort of tangible changes you could name that had been made in response to the threat of Delta. Now, you didn't name any then. I wonder if you could tell us if anything's changed, if there are any tangible changes you've made in response to the Delta threat in the last 3 weeks, particularly the last week. For example, I know you might say you've increased the frequency of wastewater testing, but it leads to the question of why we were doing weekly wastewater testing for a virus that incubates in a couple of days.
Well, first of all, I reject your summary of what I said last time we had this conversation at the committee a few weeks ago.
Can you remind us one of your names?
But you have identified some of the shifts that we've made. So more frequent wastewater testing, more frequent testing overall, including of people coming into the country through the border. So more frequent testing of people in our managed isolation facilities, both the returnees coming into the facilities and also the staff who are working in those facilities. You'll see a lot more work being done around infection prevention and control reviews. Again, the rollout of N95 masks, for example, to all of our frontline workers there. They've been wearing masks. They're now being required, regardless of those who are at higher risk, have been wearing N95s now. All will be wearing N95 masks. There's a process involved in making that happen because they have to be fit tested, because actually N95 masks have a degree of risk associated with them if they're not appropriately, fitted to people for their different shapes of their faces. So that work has been happening. A lot of work has gone in over the last few weeks to consider how our response might be different in the event of a Delta outbreak. And people, I think, will see that our response this time around has been different to the way we've responded to previous outbreaks because of the increased risk of Delta.
Okay,
Thank you very much, Minister.
Okay, across to Debbie Narirapaka, followed by Dr. Gaurav Sharma, and then followed by Elizabeth Kirikiri. Debbie, you just need to unmute.
Thank you, appreciate that. Thank you, Minister. As you know, Te Pāti Māori has been extremely concerned about the lack of equity for Māori in the government COVID response. Now, 10.4% of tangata whenua vaccinated validates this. And our concerns are, what is the government Māori COVID response plan to address this, and what specific funding stream has been allocated for Māori hapu and whānau ora providers to address the surge testing and vaccination and to match the growing contacts and response and to the community risk?
Well, first of all, if I start at the early part, so testing, Māori have held up their end really well when it comes to coming forward and being tested when we have asked people to come forward to be tested. And so I want to acknowledge our Māori communities for that leadership, for their willingness to do that. In terms of vaccination, we know that Māori have not been as highly represented in our early groups for vaccination. In terms of our border workforce and our health workforce, Māori are not as represented in those workforces as they are in the general population, and that's had a contributing factor to the vaccine rollout. But also the sad reality, and the member will be very aware of this, Māori don't live as long on average as other New Zealanders, and so as we've been working our way down through the age groups, again, Māori have been disproportionately underrepresented in New Zealand's older age groups, and I think everybody on the committee, I hope, would agree that that's a damning statistic for New Zealand overall, and it's something that we should all be concerned about. So yes, we're absolutely focused on how we rise to that equity challenge now that we're only days away from vaccines being available to every New Zealander. And that includes dedicated funding to our Māori and Pacific health providers to make sure we're reaching out further into those communities. We've done a lot of work around making sure that our vaccinator workforce is more closely connected with the communities that we are trying to reach. And that includes reaching out and training more vaccinators who are Māori and who are Pacific, because we know that that will help to encourage uptake there. There is dedicated funding available for our Māori health providers now, and there has been since we started rolling out the vaccine, and that continues to be an area of focus for us. We're also, and I think this has actually been one of the nice parts of our campaign, that there has been a lot of marae-based vaccination going on, and there's been a lot of non-Māori New Zealanders going into marae to have their vaccinations, and I think that has been fantastic, and I welcome that, and I welcome the partnership that we've had with marae in doing that work. I think that's been really encouraging.
Minister, out of the 137 million to the Māori vaccination program, how much of this has actually been delivered to the Māori providers?
I'll get our health team to provide a breakdown on where the money has flowed to so far.
Do you believe, given the surge and the growing context, that, and totally support that there has been funding for our Māori providers to date, but actually it's increased, and you can see the amazing stand-up that's been going on with our hauora providers working till 8 o'clock at night in the rain and the weekends. Do you see, and will there be a proposal to Cabinet for an immediate increase in baseline funding for our hauora and whanaora providers who are providing that frontline support across the vaccination, testing and welfare packs?
I'm sort of mindful that I could get myself into even more trouble this week if I start to make financial decisions on behalf of the Minister.
You've started off pretty good.
on behalf of the Minister of Finance before we've made those decisions. But what I can say is that we are regularly looking at where the system is under pressure and where money's being spent to look at where we need to put more resource in to keep up the good work that's been going on. So if our hauora providers are over delivering, on vaccines and on testing and so on, then of course that is something that we would look at. I think I could see that the health may have the breakdown that you were looking for before, so I'll just hand over to them.
Thank you, Minister. And the numbers I've got are in relation to the vaccination programme. We have three sources of funding for Māori providers and for Pacifica providers. One is the stand-up costs, and for that we have so far allocated $24.5 million to Māori providers, $10.5 million to Pacifica providers. We also have a communications fund which has been sent out. That's $2 million for Māori and $1 million for Pacific. And then on top of that, we have a pay-per-dose system, which is an automated payment system. So each of the providers through primary care, as soon as they load a consumer into the immunisation register, that allocates a pay-per-dose funding for them. And I don't have the total amount that we've paid out to Māori and Pacific providers so far, but we could certainly get that for you.
That would be great. So I think that's approximately 40 mil out of the 137 mil allocated. Is there more to come from that, or are you suggesting that the 100 mil left is what that paper budget represents? I guess what I'm hearing is of the 134 mil, what we do know, or 137 mil allocated, what we do know is that only 24.5 million has gone to Māori.
That's for setup costs, and then there's the pay-per-dose. And as I say, I don't have the breakdown for that, but we can certainly get that. I think we've also been clear and continuously work with providers to make sure that they are appropriately funded. And if they're setting up new models of care, for example, drive-through that incurs additional costs, we will fund those as well.
Minister, can I request that there be investigation in looking at the low percentage of investment that has gone into Māori versus the low uptake of vaccination? Is that the reason why Māori have not been able to get the level of vaccination we would expect at this stage?
No, one of the things that I would say there is, I get a breakdown regularly by age cohort and then broken down by ethnicity, and it shows that Māori vaccination statistics as a proportion of the applicable age cohorts is actually looking quite healthy. As I indicated before, I am concerned that Māori are underrepresented in those older age cohorts, but of those who are in those cohorts, they have been coming forward and they have been getting vaccinated, and that is encouraging. So I don't think it's fair to say that that the system isn't delivering. It is a reflection of demographics. I am mindful, however, as we get into younger age populations, that there is a possibility that the equity challenge will grow. And so I'm very, very mindful of that and making sure that we are doing everything we can to get ahead of that. And that includes a very active work with our hauora providers to make sure that we're reaching into every community we can to provide those people with the strongest possible opportunities to be vaccinated.
Thank you. I just wonder if there's 20% uptake of that 137. Oh, sorry, I've just got one last. I just worry about that. So my last question to you, Minister, and thank you, is to what extent are you taking on board the professional advice, the Māori equity advice that's coming from Te Rōpū Waka Kaupapa Uruta?
Absolutely. Look, we have advisory groups like that for a reason, so that we can get their advice. It doesn't mean that, and we have had some disagreements with some of the members of that group earlier on around the shape and the look of our overall sequencing framework. They didn't all agree with the age-based banding, if you like, of that. And so yes, we've had good, free and frank conversations with them, and yes, we'll continue to do that.
Okay, thank you, Minister. We've just got a sup from Arana Williams on that question.
Kia ora, Minister. Thank you for the opportunity. yeah, just following on from what you said, being days away from vaccines being available to all New Zealanders, what we have learnt from the by Māori for Māori parts of the vaccination rollout. I'm thinking particularly of Manati Womenai here that hit 20,000 vaccinations in July, that did 300 yesterday, and they've been having some success with the whānau-centred approach, whereby whole families in South Auckland are coming in with their kuia and kaumatua. Can you speak to how their sort of innovative approach in Māori and in Pacific communities is something we'll sort of continue to learn from throughout the rest of the rollout?
Well, can I just acknowledge the role of marae up and down the country, not just in vaccination rollout, but actually in our COVID-19 response, and constantly adapting and evolving to the challenges that have been thrown their way and thrown in the way of their communities. And when I say their communities, I don't just mean their Māori communities. They've actually been reaching out into the wider community and playing an enormous leadership role. And I think we should all welcome that. I think that's been really good. In terms of the work around vaccinations, I think a marae-based vaccination has been a really, really positive experience for anybody who's taken part in that, and that includes the non-Māori who have taken part in the marae-based vaccinations as well. So again, a thank you to the marae for doing that. We're always looking at what's working well with vaccination delivery, how we can get more vaccines out the door quicker. Primary care, more and more primary care is coming on board every week now, and particularly with the level 4 lockdown, when many of those primary care practices aren't doing many of the other things they would normally do, that's significantly increasing capacity. So, you saw over 60,000 doses being delivered yesterday, a really, really good day for vaccine delivery. And I think, and on a per capita per day basis, we're amongst the highest rates in the world at the moment, and I'm very encouraged by that.
Okay, thank you, Minister. If we go to Dr. Elizabeth Kirikiri next, and then Dr. Shane Reti, and then Dr. Gaurav Sharma after that. So, Elizabeth.
Kia ora koutou, thank you for joining us here. I wanted to follow up on some of the issues around Pacifica communities. What we're seeing with them being such a huge percentage of the numbers, it's a real concern. And you've answered some of the questions about support for local providers. What we're seeing is a lot of increased racism against them. And I just wonder if there's particular strategies you have for dealing with that, or how you might want to address that maybe in some of the comms. And yeah, generally what kind of support are you in? Apart from directly to providers, is there any other support going out to, say, local churches or other leadership inside Pacifica communities to help deal with this?
Well, thanks for the question. And obviously I'm really concerned to hear of any suggestions of racism anywhere in the COVID-19 response. We've been very focused since the beginning of our response to COVID-19 across every aspect of it, to not be pointing the finger of blame, to not be, trying to generate any kind of stereotypes, and in fact to try and challenge those where they have emerged. So if you have examples of those now, it's probably, you probably won't want to share them publicly and thereby reinforce them. But if you do want to share those with us, for us to follow up, very, very happy to follow up on anything that you might have heard that needs to be challenged. Because, overall, I think one of the successes of our COVID-19 response is New Zealanders have overall embraced the notion that we're all in this together, and that actually it's a virus. It's the virus is what the problem is, not the human beings. And the human beings, whatever their ethnicity, whatever their background, are actually the solution to this, not the problem.
Kia ora. Staying with Pacifica people, just some concerns too around immigration status. Is there going to be an amnesty for overstayers or people who having issues with that status over the course of the lockdown?
Something that Cabinet Ministers have been actively considering is what we do about all of the variety of different immigration and residency and visa challenges that we have in front of us at the moment. My colleague Chris Farfoy is the one to ask questions about that. But what I would say just around testing, contact tracing, vaccination, is we will not use information collected through that process for any purpose other than for COVID-19 response. So if someone's coming saying, I don't want to go and get tested, even though I think I might be at risk because my visa's not current or for whatever other reason, any information we collect through testing, through vaccination, through contact tracing, people can supply that knowing that we will not use that for other law enforcement purposes, because the last thing we want is people hiding and increasing the risk because they're worried that by sharing their information, they're putting themselves at a different form of risk.
My last question is around concerns of people with disabilities that can't get in a car and wait for hours, that will struggle to be there, can't be away from their children. Just what kind of provisions are being put in place to maybe test in people's homes, or, you know, make sure that people have the places of testing and vaccination are accessible to them?
Yeah, we're seeing some really good, innovative, on-the-ground examples of where our primary care providers, our DHBs, are going out of their way to make sure that everybody has access to the COVID-19 testing and vaccination that they need. Might ask the health team to provide further comment on that.
Kia ora.
Well, thanks, Minister. Kia ora. So just a quick comment in that is that if people, for whatever reason, are not able to get out of their home into a testing centre or to a GP to be tested, they can bring that to let Healthline know that, and there is the option for mobile testing if that's needed.
Kia ora.
Okay,
That's me, thank you.
Okay, across to Dr. Shane Reti and then Dr. Gaurav Sharma.
Thank you, Minister. A couple of questions. First of all, a data question that may be better returned after the committee, but it's the proportion of Māori who have been close contacts, who have then been tested positive, were hospitalised and or went to ICU. So if we follow that whole pathway from close contact to potentially ICU, I don't expect an answer here now, but maybe if that could be returned to the committee, that would be useful. I'm also interested in what is the age of the youngest person who's tested positive, and do we have any reason to suspect, or do we have any numbers around the positive cases that might have occurred despite and during level 4 lockdown, apart from household bubbles?
So if I sort of work my way backwards, in answer to the first part, yeah, we'll supply a breakdown of that as soon as we can. We do collect information around ethnicity of contacts and so on as much as possible. So where we can provide a breakdown of that, I'll get the team to supply that. Might take them a bit of number crunching to pull it together, but we'll certainly see what we can do there. In terms of age profile, we do know that Delta variant is infecting younger populations more readily than some of the earlier variants of the virus. And we're seeing that in our current response, and I'll get the health team to comment on the overall age profile and the specific cases that they're seeing coming through there. The last part of your question, I'm just trying to remember what that was. Yeah,
the number of positive cases who may have transmitted despite and during lockdown other than a household bubble.
So I guess one of the good measures for us there is what our contact tracers are telling us about what they're learning about cases when they get in contact with them. They're finding that people are at home, they are isolating, they are following the rules. Of course, we did have a 48-hour period after we went into level 4 where people were still moving to get home and so on. And some of the events that people might have attended that are events of concern for us, people then travelled thereafter to get back to their primary place of residence. And so that has been a feature that's been a concern for us during this current investigation. But I'll hand over to the health team.
Thanks, Minister. So just a couple of responses. Even from the data I've got from a few days ago, where we had, which was the breakdown on the first just over 40 cases. Our youngest case was aged under 1 year of age.
Wow.
Half the cases were under 20. I think that age profile may well have changed since. At that point, we had no Māori cases, but I understand there's at least one, I was told yesterday, since then. We've not had anyone in ICU at this point, and we've just had the 8 people in hospital so far. And to your other question, this is the data we really are wanting to get now, which is around, now that we're at this point in the outbreak, and we should stop finding cases that were there from before the lockdown, from the alert level 4. So we want to know how many of them are essential workers who may have been out in the community, how many were not isolating for whatever reason and therefore may have been infectious in the community, and also early as quickly as possible. And we'll try and get this information by the end of each day on the cases that have come in overnight, where they've done that first screening interview at least on everybody, those that are clearly linked to a location of interest or a known case, even if there's not the individual to individual epidemiological link established.
Okay, thank you. So a child under 1 is the youngest in this outbreak to date?
That's correct.
Okay, that's useful. My final question then is around primary care, and it's GPs asking what is being done to support them who are now picking up a large part of this load as you're describing. And secondly, the Pharmacy Guild tells me that only 12 of the roughly 400 Auckland metropolitan pharmacies are onboarded to give vaccines. How do we explain that and what's being done about that?
So I'll get the health team to comment on that. Just on primary care generally, they have been among the later parts of the vaccination process, to some extent for good reason. If you may recall, when we started this process, we were dealing with limited supply of vaccines. We wanted to do that to get those vaccines out in the most efficient way possible. And we were also dealing with a vaccine with a very short shelf life at that point. So it was only 5 days out of the freezer before it had to be discarded. We've now got a longer shelf life. We've got greater supply. So bringing on board those sites that can do fewer vaccines over a longer period is much more a feature of the vaccine program now than it was previously. And so we're seeing primary care pharmacies and GP practices coming on board at quite a rapid rate. And of course, we want to see that accelerate, but I'll ask the health team to comment.
Thank you, Minister. So I only have the national numbers. I don't have the Auckland specific numbers. We've got 519 total active primary care sites at the moment, of which 143 of those are pharmacies. 289 are medical centres, and then other whole order providers that we've already discussed. What I would say is that pharmacy providers are doing two things. One is providing in their own retail premises, but also we've got a significant number of pharmacy providers providing some of our outreach clinics and our workplace based clinics as well. So they're partnering with commercial enterprises and the businesses that we've been piloting as workplace based. They were also absolutely critical in vaccinating in our aged residential care settings and other mobile settings.
Thank you.
Thank you. Thank you, Shane. And we've just got one sup from David Seymour before we move on to Dr. Gaurav Sharma.
Oh, yeah, I just wanted to go back to something. It was actually on something Dr. Bloomfield said in response to one question earlier, just about the lag in getting test results, the fact that we're still getting cases that were perhaps caught or infected, before the lockdown. So can you give us a sense of how far in the rearview mirror are we looking? Because it seems you've got 5 days from infection to testing. Then you've got to actually do the test. And then it sounds like the delay in getting lab results back is about 48 hours. So if you do 5 + 1 + 2, are we really saying that there's what we're seeing in the daily results reflects what was happening in terms of infections 8 days ago? Is that about right?
Actually, it's a mix of some of those early sort of pre-lockdown infections where people will have been isolating and they may have already been tested, but tested negative initially, but it's the day 5 test where they've returned a positive test.
Sure.
But an increasing number of the positives now are actually close contacts or from locations of interest rather than people who actually were infected pre the lockdown. We're still just seeing a few of the latter, but most of the cases now are expected close contacts or people who have been identified as being a location of interest, have been isolating and tested. And those, if people are close contacts, especially household or from an LOI, then they are prioritised for testing and the results turned around very quickly, sometimes even within a matter of hours.
Yeah, so can you just tell us the average,
final question, David, and then
the average
we'll move
processing
on.
time for the positive tests?
I don't have that specifically, but we can look and see if we can get that. We don't usually report it in that way, but we'll see if we can get that.
Okay, thank you.
Thank you, Dr. Bloomfield. Okay, next to Dr. Gaurav Sharma and then followed by Simon Watts.
Thank you, Madam Chair. Kia ora and haere mai, Minister Hipkins and the officials. Really appreciate your time and coming in front of the committee. Minister, I just wanted to go back on just pick on something that you said before, which is comparing Delta to what's happened before. Last year, the Auckland August cluster saw the cases go up to 179, and then Auckland went into alert level 3. The rest of New Zealand was in alert level 2, but this was before Delta came on. Can you tell us a little bit about what we've learned from Auckland August cluster from last year and how we're putting those lessons to use in response to the current outbreak? I know you mentioned it briefly. And can you tell us more about how your response this time around has had to adapt to the new threat of the Delta variant?
Perhaps if I start where you just ended, Delta has obviously meant that we've had a much swifter and more severe, if you like, response than we might have done previously. We had reached a bit of an equilibrium previously where we had good confidence in our contact tracing system to be able to get ahead of any cases, isolate the risk and try and minimise the amount of restrictions that had to be put in place. And I think we've seen examples of where that happened quite successfully. So, if we go back to November, for example, we dealt with some cases in November. We didn't have to impose any alert level escalation at that point. We were able to really ring fence that and deal with that quite swiftly. So, yes, the Valentine's Day cluster, for want of a better term, did result in some alert level escalation. I think one of the lessons from us is that we probably stepped down too quickly and then we had to step back up again. And I think we'd all want to try and avoid having to have that happen again in the future. And so that was certainly a clear lesson from that. And you saw from the report from Brian Roche and his group that there were lessons to be learned. But we are dealing with something this time around that is quite different to what we've dealt with before. So, we have to respond to what's in front of us, not what was in front of us when we last dealt with it.
Okay. Thank you. Any further questions there? Otherwise, across to Simon Watts.
Thank you, Chair. Look, my question to the Director General. So official information shows that DHB's told the Ministry of Health a year ago that our ICUs were in crisis, lack of beds and critical workforce shortages. We've got ICU clinicians in the public domain now saying that while they've got more equipment than 18 months ago, they've got very few extra staff, and in some instances they've got fewer, and that the actual resourced ICU bed capacity on a day-to-day basis has not risen in the last 18 months. My question is why has the government failed to prepare? And two, do you accept that our health system has a workforce crisis?
Perhaps if I can make a comment and then I'll ask the Director General to add to that. We are acutely aware of the staffing pressures that our health system faces at the moment. That's not something that any one government can wave a magic wand and solve. If you look at the amount of time it takes to train people to do most of the jobs in question, it extends beyond the term of a single government. It is something that takes quite some time to do, to turn around. We do have processes in place at our border to prioritise health workforce people coming into the country as part of our short-term solution to that. That prioritisation has been in place since our border restrictions were first introduced. So we were acutely aware that we could not afford to have health workers stopped at the border and unable to come into the country when we're dealing with a global pandemic. So we've had provision for that. But yes, we've solved some of the things, well, not solved, but we've improved some of the things that we were able to improve within a shorter space of time, like making sure we've got more ventilators and more equipment available, and we've been able to do that. But the workforce, the overall health workforce is still under pressure. And I'd make a further observation that in any country that's been dealing with a COVID-19 outbreak of any scale, they've scaled back doing a lot of other things that their health system would normally do. Our health system has continued, bar level 4 restrictions, to do all of the things that we would normally expect of it. All of the sort of elective surgeries and all of the other things that we ask our health system to do, they've continued to do. We're one of the few countries in the world that can make that claim over the last year and a half, that our health system has dealt with COVID-19 and the big scale of that challenge, testing, vaccination, and so on, whilst still doing everything else that it does. But
so Minister, how many ICU nurses have you brought in via immigration in the last 6 months?
Look, I don't have a detailed.
Right. Well, that's you should be over that detail, because and why are you restructuring the health system in the midst of fighting on a war of COVID and doing the largest scale vaccination program we've seen in history, and you're completely restructuring a health system? I mean, where is the priority?
Well, I think that some of the challenges that we faced in the COVID-19 response highlight the fact that there are some systemic weaknesses in our health system that the government is absolutely committed to addressing. The variability of the COVID-19 response around the country is something that we've been concerned about. The lack of let's be frank about it, national levers that governments can pull to get things happening when we need them to happen and when we want them to happen and when we need them to happen has been one of the challenges that we've had to manage through the COVID-19 response. And so I think that's highlighted that we've got a health system that does need to change. But again, in terms of your question around ICU capacity, I'll go back to that and invite Dr. Bloomfield to comment on that.
Thanks, Minister. Just 2 comments to add. And yes, our ICU staffing and beds are under pressure, and New Zealand, as we know, has got a lower rate of ICU beds per capita than many other countries, and particularly if you compare us with Australia. There's a 2-pronged approach really to addressing not just that issue, but our whole health system, and the first is to protect it from the virus, and that's why the approach we've taken right from the start has been one of the key drivers has been to not have our health system overwhelmed, and I know that my colleagues in ICU and across the system completely endorse that approach. The second is, of course, to make sure when we are in this sort of situation with an outbreak that we have freed up as much ICU capacity as possible. And over the last few days, at least possibly the last week, our ICU beds have been about just over 50% occupied. So the capacity is there should it be needed, but our predominant approach, of course, is to avoid it being needed.
Okay, thank you. So to Tangi Utakiri and then across to Chris Bishop to finish.
Thank you, Madam Chair. Thank you, Minister and team. Kia ora. Minister, last year the Prime Minister introduced the country to the COVID-19 alert level system, which we obviously still rely on to keep our communities safe. And I'm interested in hearing from you about how that alert level system has been flexible, how it has changed, what improvements have been made. We're a year and a half on in order to protect the spread of the virus and obviously to cause disruption to communities.
I can tell you as one of the ministers that was involved in the very early part of our first level 4, level 3, level 4, level 3 lockdown, a lot of the discussion that took place at that time was what do we actually need to have happen to keep the country operating during that time? So what is an essential service? What should be allowed to happen and what shouldn't? And we've continued to have those conversations in the intervening period between then and now. And our alert level framework has continued to be refined, looking at what does need to happen, what doesn't need to happen during that period of time. How do we make sure we keep our supply chain open, make sure that people don't have to worry about running, supermarkets running out of produce and all of those sorts of things. So we've continued to refine that. You've seen other changes to our alert level system, including the introduction of masks, the introduction of more compulsory contact tracing measures. Just the most recent changes in that regard were announced just in the last few days. So we're constantly looking at how to improve our alert level system, and we'll continue to do that. I know that there's been suggestions, for example, rather than having a 4-level system, we should have a 7 or 8 levels. The reality is New Zealanders know and understand our 4 alert levels now, and there is real value in that. People know what is expected of them at level 4, at level 3, and at level 2. And if we if we change the fundamentals of the system, then people would have to learn a whole new set of systems all over again. So we can use them strategically, including by imposing regional boundaries, and we have done that from time to time by differentiating different parts of the country, and we have the ability to do that.
Thank you.
Thank you, Minister. Just clarifying, would you be available for another 5 minutes or 10 minutes just to stay on for one or two more questions?
Yeah, sure. I could probably do to another 5 minutes.
Another 5 minutes. Okay. So just handing over to final questions from Chris Bishop then.
Thanks very much. Minister, in relation to vaccine contracts, government announced it had signed on 12th of October last year an agreement with Pfizer. Was that a concluded agreement, or was that more a heads of agreement?
It was certainly an agreement for the supply of 1.5 million doses of the vaccine, so the equivalent of 750,000 people's worth. And that was part of an overall portfolio of vaccines. You'll recall that we also had purchase agreements around that time with Novavax, AstraZeneca and Janssen as well, different quantities and different options on doses available from all of them.
Is it correct that there was a further agreement with Pfizer in December 2020?
I'd have to ask the vaccine team to provide details on that.
Can you come back to us on that?
Yeah, certainly can. Yeah, there was certainly a further agreement early this year when we agreed to significantly increase the order.
Yeah, but my understanding is that there was a heads of agreement in October, and then there was a concluded agreement in December. So perhaps if you could come back and give us the timeline on that.
Sure.
Can I ask why the government did not, or has not, in the last 9 months, gone to Pfizer and asked for earlier and quicker delivery of vaccines and sought to pay more in order to expedite the delivery?
We have been talking to them regularly about getting faster delivery of vaccines. At no point in those conversations have we been offered the ability to pay more to get earlier delivery. So
that's an interesting point, that you haven't been offered that, but it begs the question as to whether or not the New Zealand government has offered that. Have you done that? And if not, why not?
Look, we have had conversations with Pfizer, and again, I don't want to get into the commercial negotiations that have happened with Pfizer, but we've had conversations with Pfizer about all of the different options for securing earlier access to vaccines.
Did the New Zealand government offer to pay more to enable a quicker delivery of vaccines than what we have now?
Like I said, I'm not going to get into the commercial negotiations around our agreements with Pfizer, but we have explored with them all of the different options for getting earlier access to vaccines.
Do you accept that we have been slow to roll out the COVID-19 vaccine?
No, I don't. In terms of the vaccines, I do accept that supply has come in the second half of the year more than in the first half of the year. That is absolutely correct. But in terms of vaccines coming into the country and being administered, I think the rollout of the vaccine at the New Zealand end has been very, very well managed.
Can you give us an update on how many frontline health workers have been vaccinated?
Yes, we can provide a more detailed breakdown of that, and we've asked DHBs to report back for their workforces, and so that we can provide a more detailed breakdown, and I'll ask the health team to comment on what they have in front of them at the moment. Bear in mind that it is not compulsory it is compulsory for some of those frontline health workers, but not at this point for all of them.
Okay. A small and minor point. I've had reports from some people who are getting their second doses in the community right now, which is obviously great, but some vaccinators are saying they're not allowed to fill out the second dose part of the little COVID vaccination cards that get carried around because of level 4 restrictions. Is that the policy, or can it be sorted out?
That's a new one to me. I'll ask the team whether they've had any further reports of that, but that's certainly not. You're the first person to have raised that with me as an issue.
Well, it's just, it's going to be concerning for particularly seniors, I think, and elderly people who obviously want a record that they've been vaccinated and they want to be able to show it to people.
Sure.
Yeah.
I can see the Director General or Joe, if either of you want to quickly comment on either of those two issues.
it hadn't come to our attention, but thanks for raising it and we can clarify it with everybody. It's certainly not part of the level 4 protocol.
Okay, thank you. I've just got one final supplementary from David Seymour and then we are going to close. Just one supplementary.
Well, thank you, Madam Chair, but the Minister's indicated he could do another 5 minutes, so we've got a bit longer.
We've got 3 minutes to go. Yep. Okay.
All right, well, let's see how we could use that. Do you guys have any current tenders out, negotiations or applications sought or received to set up drive-through vaccination centres, and if so, where?
There are drive-through vaccination centres being set up now as we speak, and in fact we've got some of them being set up very successfully at scale. So we've got one in Auckland that's been doing 2,000 vaccinations a day, and there are other examples of that popping up all around the country. In terms of whether there are further tenders out for more, I'll ask Joe or Dr. Bloomfield to comment on that.
Yes, thank you. Not tenders specifically. All DHBs and all providers are being encouraged to use the most appropriate mix of models, and the payment system is the same for a drive-through model as for any other model. And certainly we've got no commercial providers, if that was the question.
Okay, fair enough. I just wonder that there's some very helpful information from Dr. McElnay on the amount of people who are contacts of varying degrees that have been tested and had their test results returned. That seems to be really critical information for people to understand how close we are to getting to the edges of this outbreak and being able to get our way of life back, go down levels. I just wonder, I look on your website, you release testing data by age, gender, ethnicity, DHB, just about everything. Can you commit to releasing data based on whether people were actually close contacts? How many of those have had test results returned on their first, second or third, so we can really get a sense of how close the government is to getting to the edge of the outbreak?
Look, I can confirm that we actually had that very conversation this morning. The ministers who are overseeing this response had that very conversation this morning about being able to provide more of a breakdown around who's being tested and what those results are, a bit more granular information there. But also one of the constant questions we're getting asked at the moment is, of those positive test results we're getting, have those people been active in the community? What proportion of those were already identified close contacts of someone and therefore isolating? What proportion of them are within a household bubble, for example, of someone else has already been tested? So we've had that conversation about, being able to present that information in a more transparent way. So we have got the team working on that as we speak, and I'll invite the Director General if he wanted to make a further comment on that.
So can we just clarify, was there any undertaking there?
Well, like I said, it's something that we've actually got the team working on at the moment, and I'm happy to give you an undertaking that we are endeavouring to provide richer and more detailed information.
Okay, just finally.
So David, that's the last question. If we were going to
well, hang on a minute. We've still got time, Madam Chair. The Minister's not trying to run off.
No, my understanding
your job's
was 5
to
more
facilitate
minutes.
asking questions.
David, there was five more minutes, which we're at now. I think Minister Hipkins had handed over to Dr. Bloomfield for comment, and then after that we will close. Dr. Bloomfield, did you want to make any comment in respect to Minister Hipkins' query?
Yes, we're at the point in the outbreak now where we are able to start providing that, collate and provide that information which Dr. McElnay shared, and so we will be able to do that, as well as the characteristics of the outbreak and the other information about essential workers and others who may have been in the community infectious.
Okay, well, thank you very much. And we are at time, so thank you, Minister, and thank you, Dr. Bloomfield. And we look forward to hearing from you again at 2:30 tomorrow. And also thank you to the Ministry's health team, and we're looking forward to discussing MIQ tomorrow. Thank you very much.